Hi, I'm Dr. Peterson, one of the EMS medical directors with Regions Hospital EMS. I'd like to briefly review the updates to our patient care guidelines for July of 2024. As with any guideline update, all of the changes are highlighted in the What's New section found in the mobile app and on page 3 of the PDF file. I'd like to highlight 4 of the recent changes. Let's start with an easy one, TXA. Tranexamic acid has been in our guidelines for several years, but mostly for tactical medics in the setting of penetrating trauma. There have been several large research studies that have shown a very clear life-saving benefit for TXA in these situations. The standard dosing regimen has been 1 gram IV over 10 minutes, followed by another gram IV dose infused over the next 8 hours. More recent data has shown that there is also benefit if TXA is given for blunt trauma, which makes it more appropriate for widespread pre-hospital use. In fact, for every 67 times TXA is given, a death is prevented. If you include not just death, but other unfavorable things like the need for blood transfusions, surgical procedures, and other complications, that number is even lower. The best part is that the risks associated with TXA are so low they are considered negligible, so we can use it with confidence. Unfortunately, hospitals have found it difficult to manage the 8-hour follow-up infusion. There's a lot going on with these sick trauma patients, and it just gets lost down the priority list. Because of this, 2 research studies in 2020 looked at the standard dosing compared to just giving the full 2 grams up front and eliminating the 8-hour infusion. They found that the outcomes were the same, with no change in risks. So to make it easy for everyone, we are following the lead of other EMS agencies and the military by changing our TXA dose to 2 grams. This applies to adults only and ideally should be given as a slow push over 10 minutes. The indications are trauma with evidence of hemorrhagic shock and the inability to control the source of bleeding. It comes as 1 gram pre-mixed in 100 mLs of saline, as well as 1 gram vials, so feel free to mix and match whatever supply is available. Next, let's talk about 2 cardiac arrest changes. The first one has already been rolled out to most, if not all of you. Chest compressions during CPR for adults should always be performed in a 30-to-2 ratio with ventilations, or 15-to-2 for infants and kids. We believe this is the best way to perform compressions, even if an endotracheal tube has been placed. Now, we are fully aware that ACLS teaches continuous, uninterrupted compressions when an endotracheal tube has been placed. However, if you look at the evidence behind this, there is actually no survival difference between the 2 techniques. In fact, when 30-to-2 is done correctly, there might actually be a slight benefit. ACLS still recommends continuous compressions with an ET tube because 30-to-2 is really not that easy to do correctly. But the Lucas device makes that irrelevant for us. So based on data we have seen with ECMO patients, when they first arrive in our ED, the patients receiving 30-to-2 compressions show better ventilation and perfusion than those with continuous compressions. Our belief is that even with an ET tube, it's just too hard to adequately ventilate someone when you're fighting against the compressions. Now, this is an easy change for us, but also please understand that we don't control how hospitals practice, so direct any questions or concerns to us here at Regions Hospital EMS. The second cardiac arrest topic is dual sequential defibrillation and vector change defibrillation. A recent well-done study from Canada compared standard defibrillation against vector change defibrillation and also dual sequential defibrillation. To summarize the results, standard pad placement is fine, changing the vector is better, and dual sequential is best. Unfortunately, your monitor's manufacturer will likely void your warranty if you try to combine shocks with another device. So for that reason, many agencies and hospitals are not going to be performing dual sequential defibrillation. So the next best option is to change the pad vector if your first few shocks are not successful. The two vectors include the familiar anterolateral pad placement and the anterior-posterior pad placement. All you have to do is slap a new set of pads on in the other orientation and keep shocking. For logistical reasons, it makes sense to use the anterior-posterior placement for the initial set of pads, so you don't have to worry about the Lucas device backplate when you switch vectors. Now, ECMO is absolutely still on the table for these patients, so this does not change the need for early activation and rapid transport. But ROSC is always preferred over more CPR, so don't forget about the vector change option when you're transporting. The last update is a simple one. We added a page to the reference section to remind you of the MIST format when you transfer your patient to the ED staff. This is a simple, structured format that can be used for both trauma and medical patients and provides the most important elements for a concise ED report. The ED staff can always follow up with additional questions after you hit the highlights. This format is being encouraged of all EMS agencies throughout the Twin Cities for any critical patient. So spend a minute before you arrive at the hospital to make sure you are prepared and have included all of the important pieces of information. Well, those are the highlights for this guideline update. Please reach out to your clinical supervisor if you have any questions. Thanks for watching and stay safe out there.